Well, hello everyone, and welcome to our first in the series of Saturday Conversations, Talk with a Doc. So we're glad that you're joining us. To help us kick things off, we are very honored to have Dr. Devina McCray, breast oncology surgeon with Advent Health here in Orlando. If you will start by just telling us a little bit about your background and where you went to medical school and all that good stuff.
Sure. My name is Devina McCray. I went to medical school at the University of Colorado. I'm from Indonesia. I was born there, but brought to the United States at the age of 6 months. Grew up in Los Angeles and just moved around from college. California, I went to University of Colorado for college and then medical school, and training throughout my medical training journey has taken me all over the country. I was here in Central Florida for my general surgery residency, and that's where I met my husband, who Vanessa knows. We then traveled around some more. I initially wanted to be a heart surgeon, a cardiac surgeon, and started my training doing that. We went back to Los Angeles, and there was something missing in my life, and I took a U-turn, left cardiac surgery, and felt my calling was to focus on breast and breast cancers in patients. So here I am.
Well, we're glad to have you back here in Central Florida. So you are a breast oncology surgeon. So let's talk about this. At what point in the breast cancer journey will a patient see you?
Initially. So at our institution, Advent Health, we have what we call the multidisciplinary clinic, and the majority of the cancers may have already gotten diagnosed since they go through their screening mammogram, or they have a lump that has been detected by their primary care doctor, which will then unfold into a biopsy leading to the cancer diagnosis. And so then these patients will be seen in our multidisciplinary cancer clinic, where they will see the surgeon, myself, a medical oncologist, and a radiation oncologist, all at that one visit. So it's very beneficial in that patients don't have to take 3 afternoons off. It's just one afternoon to see all 3 of us. And they love to see that their doctors are communicating with each other, and the time to treatment is much, much shorter.
So, go ahead. Did you have something else?
Also, there are times where I detect the lump, or they come in and they say I have a lump, and we start going through the diagnostic imaging, and I may perform the biopsy in the office prior to even a cancer diagnosis. I also follow high-risk patients, and so when I'm seeing them every 6 months, there may be something that was on their mammogram that I can easily biopsy in the office. So at that time, they will initially see me.
So let's go through the steps here. First of all, let's talk about the self-exam. There's a lot of controversy about whether that is beneficial. And for a long time, we heard that every month, do that breast self-exam. What's the latest on that?
So the latest is it's not recommended, which I have to disagree with. I really am a firm believer that you know your own body, and detecting that difference in your breast. Sure, everybody's breast is lumpy, especially when you're young, and you're going to feel that cyst. You may feel a benign mass, but that change is what can lead to an early diagnosis. And so I always recommend women to still know their body, know their breast, check yourself every month, look at yourself in the mirror first, make sure there's no dimpling, there's no retraction of the nipple, there's no changes in the skin. And each month, the best time, especially when you're premenopausal, is that day 7 to 14 days. So day 1 being the first day you start your period, and then counting 7 to 14 days from there, because that's when your breasts are the least active from your menstrual cycle and your hormones. But My take is I do believe that women, you know your own body, and if there's a change, then you can quickly see a physician to start the evaluation.
So let's talk about the mammogram.
Mhm.
Over the years, speaking of controversy, there's been a lot of controversy on that, when you should get that first mammogram. So for mammograms, let's talk about that first. When should you get the first mammogram?
There is many differing thoughts. Some recommend starting at the age of 45. There is another recommendation starting at the age of 50, doing it every other year, stop exactly at the age of 65, which I completely disagree with. This is my take. It has been proven over and over through peer-reviewed studies that starting at the age of 40 has decreased the breast cancer related deaths. So women who get their mammograms at the age of 40, you have a 15% decreased risk of a breast cancer related death. If you're getting a mammograms at the age of 50, you have a 22% reduced risk of developing a breast cancer related death. Women in their 60s who get their mammograms annually, a 32% decreased risk of developing, of a breast cancer related death. So these mammograms are saving lives because we are detecting cancer at a much, much earlier stage, and women have many options and many options for treatment, and the cure rate is 98, 99%. So my recommendation, if you are at that normal population risk of 12 to 13%, 1 out of 8, then you should start your mammograms at the age of 40. It has been proven that getting it annually also decreases the breast-related death risk. And as far as when to stop, I don't think there should be an age. I see women who are 90 and healthy. I think the eldest I've ever operated on was 102. So as long as women are healthy enough to receive treatment, then they should absolutely continue getting their mammograms.
When you mentioned 102, I saw everyone's faces like, that's amazing. What if you have a family history, and what determines family history? Are we just talking about if you're a biological mother, or are we talking cousins, aunts, sisters? What's family history?
Right. So close family history is considered first generation. So mother, father, grandmother, brothers, sisters, as well as aunts, uncles, and cousins. And so when someone is at that higher risk of developing breast cancer because of a family history or a genetic predisposition, then they should start screening earlier than the age of 40.
With Compassionate Hands and Hearts, we have had a lot of younger patients recently, and
Mhm.
many of them have talked about the difficulty of getting a mammogram in terms of the doctor saying, you're young, it's probably nothing. Talk to us about that, because you have to be an advocate for your health.
You absolutely have to be an advocate. If you're feeling something, if there's a symptom, then go to another doctor. Um, Tell them, I have breast pain. A lot of people think breast pain is nothing, it's just hormonal. But there have been many breast cancers where patients come in and I have breast pain, and I start the evaluation, and lo and behold, it's an early breast cancer. So I think you're right. Women need to be advocates for themselves. So if there's a symptom, if they're feeling anything, if they're seeing any changes in their skin, then go in and say, or if they have a family history, go in and say, I have this family history, I'm really concerned. And if they won't get it for you, then find another doctor.
And mammograms are not the only way to detect the breast cancer. Talk to us about ultrasounds. And
So
what
ultrasounds, yeah.
ultrasound?
Mammogram is going to be your best screening tool. And as far as ultrasound, ultrasounds are more targeted. You got a probe that's approximately 4 or 5 centimeters. And so it's not going to look through your entire breast. And it's also technician dependent. So it's an addition to your mammogram. If they see something under mammogram that they find suspicious, then, and if it's a screening mammogram, they will call you back. It's a callback. I'm sure some people are aware of their callbacks. where they will get additional diagnostic imaging as well as an ultrasound to go through that tissue and see if there's something structural that they can see under ultrasound.
And after the ultrasound, you might have to have a biopsy. So tell us what that is like.
It's like, so let me go back to the mammograms. So there are times where the tissue, and a lot of women have dense tissue. Young women have dense tissue, but dense tissue comes in all age ranges. And so we get concerned with dense tissue because it can hide something. And so, but it can also cause a false suspicious positive. And so when you get called back in for a mammogram, what they'll do is they'll do additional compression views where that dense tissue may just kind of compress out, and they're really not seeing anything suspicious there. And then they also do the ultrasound. 3D mammograms is something that we're really pushing for. The 3D mammogram is not like your traditional mammogram. Your traditional mammogram is 2 views, up and down and side to side. With your 3D mammograms, this is just advanced technology where with the compressed breast, the machine will arc over your breast, taking a few degrees at a time, giving us about 70 to 80 images. That's very important for the radiologists because they're able to more easily detect a suspicious mass under that dense tissue, because it allows for the mammogram to sort of unpeel that dense tissue. Something else is that it's actually decreased the number of callbacks and also decreased the number of unnecessary biopsies. So in talking about biopsies, when there is something that is persistent on a mammogram, and structurally when we do the ultrasound, they see something under ultrasound, there's 2 ways of doing a biopsy. The one that is most comfortable is an ultrasound guided biopsy. This is something that has to be seen obviously under ultrasound for us to proceed with an ultrasound guided core biopsy. So the radiologist or the surgeon, we also do ultrasound guided biopsies in the office, will find that suspicious area, that suspicious mass, and perform a biopsy in the office, numbing the skin really, really well, taking a small little nick in the skin and placing that biopsy instrument. It makes a very loud noise. I let my women hear this loud noise. It's like a loud click before it goes into the breast, just so that they won't be startled. And I tell them, my goal is to be better than your dentist. So I numb women up really, really well because I don't want them to feel anything. And so once she's all numb, place the instrument in, and we're taking a few snippets of that tissue. The second important thing is to place a little titanium chip, because one, if this is completely benign, then we don't want anybody else touching that benign mass, unless of course it starts to look suspicious. But that chip tells us that this has already been biopsied. Or the other route, of course, is if it's a cancer or it needs to be removed. That way in surgery, we know exactly where that biopsy happened and we can remove it. The second way of, the second way of doing a biopsy is called a stereotactic biopsy. I'm not sure if anyone's ever had this done, but this is when something cannot be seen under the ultrasound. And that's done under the mammogram machine. It's called a stereotactic biopsy. This can be a little bit more uncomfortable or less comfortable, as women have to lay on their belly as their breasts sort of hang in a hole. The radiologist normally does this because it has to be done under mammogram. Same thing, really numb up the skin, little slit in the skin, and then the biopsy instrument goes in and it removes the tissue. A lot of it, most times it's because of calcifications that are seen under mammogram. And so they remove those calcifications, take an x-ray of the specimen or the tissue that was removed to ensure that those calcifications are in there. And of course they place a chip. Now, there are times where, especially when we're screening high-risk women, we do annual breast MRIs. And if there's something seen under breast MRI that wasn't seen under mammogram or ultrasound, then a MRI guided biopsy is indicated. And pretty much the same thing as a stereotactic biopsy is just under the MRI machine. We're able to locate that area of suspicion. She comes back out and through a GPS system with the MRI equipment, they're able to find that suspicious area and do the biopsy that way. The fourth way, which we used to do more often, now that we have more technology, we don't do it as often, but is an excisional biopsy where the radiologist will find that area either under ultrasound, mammogram, or MRI, place a device, either a wire or an advanced clip that sends a signal to an instrument in the operating room. Then we take the patients to the operating room, make an incision, and then remove the tissue that way.
Well, that was great explanation. I wasn't aware of all of those different methods. So that's good information for people who might hear, like, what kind of biopsy are you having? So let's move on to your other specialty, which is the actual surgery to remove a breast cancer. We hear about lumpectomies and mastectomies. So let's talk first of all about the lumpectomy. What is it?
So lumpectomy is an option for women who are diagnosed at an early stage. A lumpectomy is essentially removing the cancer with a good, healthy margin of tissue around it. Lumpectomy is part of what we call breast conservation. When we do a lumpectomy, most women do have to follow through with whole breast radiation or another type of radiation called intraoperative radiation, but we can talk about that in a little bit. Whole breast radiation to the breast to take care of the entire breast, which makes that equal outcomes to a mastectomy, which a mastectomy is removal of the entire breast. So women with early stage breast cancer have that option of a lumpectomy. We're able to preserve a woman's breast. When I do the lumpectomies, number one is to absolutely oncologically remove the cancer. But a very close second is cosmesis is very important to me. So we are now adopting hidden scar surgery, where we either place the incision, depending on where the location of the cancer is, we place the incision around that areola. I call it the plastic surgeon's incision because they love that incision, where the dark meets the light helps really blend the scar after surgery. Another location is right underneath the axilla. So when you're looking straight on, you don't see any incisions on the breast. And the third incision that I like to perform is an inframammary incision, so right below the breast where it folds over. I also perform oncoplastic rearrangement to help rebuild the breast and rebuild the shape of the breast. So our breast is very forgiving, and so what I do is I release once the specimen is out. Once the lumpectomy is done and it's confirmed that the cancer is out, I will release the tissue around the cavity and right in the middle, sew that right back together so that the breast doesn't cave in.
That's amazing. So which one is best? Because people ask that a lot. There's a serious decision that has to be made. Do I do the lumpectomy or the mastectomy?
And it is such a very personal choice, Vanessa. And this is why screening mammogram is so important to detect an early breast cancer. Earlier stage cancers, you have many options. And one is breast conservation, lumpectomy with radiation versus mastectomy, removing the breast. Such a very personal decision. And what I tell my women is, what is going to help you sleep better at night? When you wake up in the morning and you look at yourself, looking at that natural breast, are you going to be consumed with, is your cancer going to come back? And are you just going to have that anxiety every time you have your mammogram? Or are you going to look in the mirror and see your natural breast, and that's going to empower you as a breast cancer survivor, right? So, you know, I tell women, you know, this is going to be a very difficult decision for you, maybe your most difficult decision, but this is your body, and this is you tell me, what is it that you're going to be able to live with? Is it the breast conservation where we preserve your breasts, or is it the mastectomy? The survival outcomes between the two, when women follow recommendations after surgery, are completely the same. The survival is completely the same between breast conservation and mastectomy. Recurrence is a little bit different, very, very minimal, difference of 2%, 2-3%. So with a lumpectomy and radiation, and following recommended treatment afterwards, the recurrence rate for a lumpectomy is about 4 or 5%. As far as mastectomy, it's about 2%, because we cannot absolutely guarantee that all that breast tissue is removed. So that difference is very, very small between the two. Now, if someone is at an advanced stage of breast cancer, or it's a larger area where I can't remove all of that, and it affects cosmesis. You know, there are times where there's an early stage breast cancer. However, the area of early stage cancer is 5 centimeters, and you know, a woman is an A or B cup. I can't do that lumpectomy and promise good results. And so at that time, I would, you know, more strongly recommend a mastectomy.
Two things before we go on. When you describe late stage, what would you say is late stage?
Well, of course, stage 4 is the late stage. That's when the cancer has metastasized to another organ. That's treatable, but that cannot be cured. There are many women living with stage 4 breast cancer only because the technology of our systemic therapy is so much better today. And different stage 3s, and also the aggressiveness of a breast cancer. There are later stage 3s that have lower survival, but now with our advancement in systemic therapy and targeted therapy, with each subset of subset types of breast cancer, survival is so much better, and we're only learning more and more.
And you mentioned the word cosmesis, if I'm pronouncing it correctly. Is that just the cosmetics?
Cosmetic outcome.
Okay.
Mm-hmm.
So that was doctor speak. So I wanted to make sure that everyone got that. And you mentioned something about radiation. So what did you want to say about that?
So radiation, it is part of the breast cancer treatment. The majority of lumpectomies will require radiation to the entire breast. However, we have found that we can do one-shot radiation in the operating room. So let me just back up a little bit. Traditional radiation to the lumpectomy and the entire breast is approximately 4.5 weeks. It used to be 7-8 weeks, but that's also, we've been able to de-escalate that and show that there is no benefit in giving more radiation. Now we have found that for very favorable cancers, that we can do the lumpectomy and in the operating room place a balloon. While in the operating room, the radiation oncologist then comes in and we can deliver that radiation in 15-20 minutes to that lumpectomy site, and the outcomes are completely the same to a lumpectomy with whole breast radiation.
What about for someone who has breast cancer and has the mastectomy and then makes the decision, I just want to have them both removed? As a surgeon, what do you talk to your patients about when it comes to that?
So we're looking at other risk factors. Are they at a genetic predisposition? Did they have a strong family history, and did they get tested for genetics? If they are diagnosed with a genetic predisposition, like we all know, the BRCA1 and 2, I call it the Angelina Jolie gene because that's how everybody knows it. But that's not the only gene that increases your risk of breast cancer. There's many other genes that increases that. So So anyone with a family history and you're going in and speaking to either a doctor, your OBGYN, a genetic counselor, please, please, please let them know all of the other cancers, not just breast or ovarian, but colon cancer, melanoma, pancreatic cancer that's in the family, because then they'll recommend an expanded panel to look at more than just the BRCA1 and 2. So if someone is at a genetic predisposition, then yes, the recommendation, there's a strong recommendation for a bilateral mastectomy, because you're still at risk of developing breast cancer, on the other side, a higher risk. I don't push it. Unless there's another cancer there, I really don't push, even if there is a genetic predisposition. There are some women who want to save their breast. And so I tell them, if you are against getting a bilateral mastectomy, then that's okay. You just have to make sure that you follow me throughout your survivorship and make sure that we're getting all the mammograms or even the MRIs and the ultrasounds, just to ensure that you're not hit with that other 60% chance of developing breast cancer on your other side. But most women do. Whenever there's a genetic predisposition, they will opt for a bilateral mastectomy. The other thing I wanted to say was, if there is no genetic predisposition, then we are made to say that there is no survival benefit in doing a bilateral mastectomy when there is no genetic predisposition. However, this is my take. We don't know every mutation out there, and someone with a high someone with a significant family history, or someone who's really young. I have 24, 25-year-olds that I'm treating with breast cancer, and why are they getting breast cancer? So, someone in that situation and they want a bilateral mastectomy, then I completely support it. But, as we have to follow our recommendations from our society, if someone does not have a genetic mutation, then there is no survival benefit in doing the other side.
If you've had the mastectomy, do you still need to get a mammogram?
No. So what I do, this is my protocol, is women who have bilateral mammogram, they will see me every 6 months for at least 5 years. A recurrence will be detected superficially at the skin. And so I have them follow me. And if there is something that I'm suspicious of, I pull my ultrasound out really quickly to make sure that there isn't anything suspicious. Because after mastectomy, and some women may know that there can be a lot of scarring, and that can worry patients. So that can be easily seen under ultrasound, or if there is more of a suspicion, then a breast MRI will be done. But no, as far as a bilateral mastectomy, annual screening mammograms are no longer recommended. Obviously, if you only have one-sided mastectomy, then the non-cancer side, you will need to continue with annual mammograms.
Okay. If anyone has any questions, I see a couple coming in. If you can just wave or do the raise your hand, or go in chat and let me know if I haven't covered your question yet. So while they're doing that, talk to us. Oh, did someone raise their hand? Oh, okay. While they're doing that, can you talk to us a little bit about, Lisa has a question. Lisa, go ahead and unmute yourself and ask your question.
Hi, Dr. McCray.
Hi.
So I had bilateral cancer. I had tumors in each side. So I opted for, obviously, bilateral mastectomy, and then followed by deep reconstruction. So I'm not with Advent Health, so I'm on the other side. So I get very anxious every time I go to the oncologist. I'm like, how do you know that I don't have cancer? Because I've actually asked before, and this is not the protocol, to have a yearly MRI or a scan just for peace of mind. Because a couple of times I'm on my 5th year being cancer free. So there's been a couple of times where I'm like, I kind of feel something, because with the deep, it's your stomach tissue, and it just sometimes feels a little weird. But it's just, I hate going in there and being anxious with them, and sometimes I get a little upset. but they try to calm me down, but I'm just curious why. And for me, especially because I had stage 2 on the right and stage 0 on the left, to me, that's kind of a lot of cancer to have. And then to not follow up afterwards, just to make sure the doctors were all fairly certain they got it all, but
Sure.
it's just still, it's nerve-wracking it's just, I don't know what else to do, and I do feel bad when I go in there because sometimes I yell.
Well, um, at the Cleveland Clinic, at my fellowship, we actually did do annual mammograms on patients who had mastectomy with DEEP. We looked at it. We compared the ones with that weren't doing mammograms and the ones that were doing mammograms, and we saw no difference. We saw absolutely no difference. And so, is it, and we actually found more unnecessary biopsies, more false positives when we're doing annual mammograms. So seeing that, that's why we came up with this recommendation of not doing annual mammograms, because it proved to have more anxiety for patients, right? But on the flip side, though, I mean, you're absolutely right. You had cancer on both sides, and you may be feeling things. And when it comes to your situation, I would be persistent. If you're feeling something different, then ask for an ultrasound at least, right? If you're feeling something, and it could just be scar. And I take such an individualized approach with each person. If they're feeling something, a lump, ultrasound. Even if there's pain that's out of proportion that isn't normal, it's an MRI, right? So that's why I continue to follow my patients. It's not going to be an annual sort of screening, but it's going to be based on your symptoms.
Okay, I still ask because I'm always feeling around now just to see does anything
And you should.
feel different.
And you absolutely should.
So a couple of times they've sent me for a mammogram, and they're like, yeah, it's just tissue that we think has died. It's just a little rough.
That's
but
what they call it.
It's still, I don't know. I guess all of us are always going to have angst that it's going to come back.
Of course.
So it's just, I don't know how else to, go about not feeling that way, but I think we'll all always feel that way.
You will always feel that way. And trust, wherever you went, I'm sure it's a breast radiologist that's looking at it, and your oncologist that's also looking at it. Because I look at all my films, and if I question anything, I'm on the phone right away with the radiologist and saying, is this something really that you think is just benign? Should we just biopsy it just for peace of mind? So, you are your own advocate. And if it's something that you are feeling is different, and, you just have this, this feeling, then, persist. Keep persistence.
Okay, thank you.
You're welcome.
Another question came in about MRIs. How often should you have one if you have been diagnosed with breast cancer? I guess it'd be after you've been diagnosed.
Right. So there's no strong recommendation. I look at a number of factors. Is there family history? The risk of someone at a normal risk, the risk of developing another primary cancer after a first diagnosis is low. And so it's not a strong recommendation to continue MRIs, but it is just, continue annual mammograms. However, there are certain situations like a strong family history, a genetic predisposition, that you should continue your MRIs, or the cancer wasn't detected under mammogram or ultrasound. A woman may have such dense breasts that an MRI was done and they found the cancer. So in those situations, I would absolutely continue annual MRIs as well as annual mammograms. There have been times where cancer on one side was detected under mammogram or ultrasound, and I ended up doing a breast MRI, and their second cancer was detected on the other side or somewhere not in that same area in the breast. So if a woman were to choose lumpectomy or save the other breast, choose a lumpectomy, then I would absolutely continue breast MRIs because that other cancer wasn't detected under mammogram or ultrasound.
All right, someone else wants to know what's in the future in terms of surgery to make all this better for us. That's a great question.
Yeah, no, that's great. That's great. There's a lot of push for doing less. We used to, I mean, it's no secret, 20, 30 years ago, we were taking out as much as we could. We were causing such deformities, such pain, taking all the lymph nodes, taking vessels that we shouldn't have been, taking, nerves that we shouldn't have been. And so we now know that actually less is better now. And so now we're able to do breast conservation, preserving women's breast. Even with mastectomies, it was taboo for us to even think about saving the nipple areola after a mastectomy. And now we're doing it more and more. Certain criteria for me, as long as the cancer is well away from the nipple and areola, I'm very happy to do a nipple areola sparing mastectomy because we have found that emotional outcome is significantly better. Hiding the incisions, so there are women who have more pendulous, larger breasts, and they've always wanted a reduction. And so when a woman is diagnosed with breast cancer and they come and tell me, well, I'd love to save my breast, but is there anything you could do on the other side to match or to decrease the size? Because I've always wanted a reduction. I say, absolutely. We can have you see a plastic surgeon and we can do what we call an oncoplastic reduction, where we do the lumpectomy and then the plastic surgeon will come and reduce both sides and lift it. So it's pretty much a free breast reduction. Insurance is paying for it because of the cancer diagnosis. And in the cancer or the breast cancer or breast oncology world, we're always striving to find out what is going to be better for patients. And there are actually two big trials, one looking at ductal carcinoma in situ, which is the stage 0 cancer that is still encapsulated and the more advanced, and then the other trial is the more advanced cancer. And we're looking at, do we even need to operate on women? Do we need these ductal carcinoma in situ? Can we just watch? Can we give them anti-hormone therapy? And will they have the same outcomes? For the advanced stage cancers, can we just give them chemotherapy and rebiopsy, and if the cancer is completely gone, then let's just watch. So, those things are out or beyond the horizon here that we're looking at. These are two huge trials that are going on right now. Other things are beyond surgery is more targeted therapy, immunotherapy for our cancers that are just more effective on aggressive cancers and specific subset types of cancers, as well as radiation. If someone is not a candidate for intraoperative radiation, maybe they may be a candidate for 1.5 weeks of radiation and not the 4.5 weeks of radiation. So we're doing a lot more to lessen the treatment, because we have found what we used to do was too much. And now we're able to sort of de-escalate treatment, and outcomes are completely the same.
Here's a question that came in earlier in the week through email about when you have a mastectomy and then reconstruction, should you start the reconstruction process soon, or is it okay to wait? And how do you know which is best for you?
That's a great question. That's a great question. Any woman with early stage cancer, they decide to have a mastectomy and they want reconstruction, should get immediate reconstruction. The more advanced, such as the dreaded inflammatory breast cancer, where it is involving the skin, reconstruction is completely contraindicated. Or a advanced what we call fungating type cancer, where it's growing out of the skin and ulcerating through the skin, because there's just so much skin involved, then that is also a contraindication to reconstruction. But however, most women who want reconstruction and have an earlier stage cancer should get it immediately. And there are different ways of doing reconstruction. And I know Dr. Feiner is going to be, I don't want to steal his thunder. He'll be talking as well about reconstruction, but there are ways that we can reconstruct. They're implant-based, tissue-based. He'll go over all that. He's the expert on that. But there's also more and more we're starting to try completely skipping the expansion process. So traditionally, right after the mastectomy, the plastic surgeon will come in and place a spacer or an expander. And you go through the expansion process of going to your plastic surgeon's office every week to get expanded, to recreate that shape of the breast. And then 6 to 9 months later, you go back to the operating room and they exchange the expander for an implant. Now we have found that we can go direct to implant. Now you have to have good anatomy to do this, so you have to meet specific criteria, but we are doing that more and more where I will do the mastectomy and the plastic surgeon will just place go direct to implant and completely skip that expansion process.
Well, I thought we would go about 30 minutes and we've gone beyond that. So if I didn't get to your questions, if you can just quickly hit the chat there, but I think I covered all of the questions that people have. Dr. McCray, I want to thank you for joining us. I think this has been a very interesting discussion, especially learning about what's on the horizon, you know, what's coming, what has changed over the past 5 or 6 years. So we just really appreciate your time. And as I mentioned, we're going to post this online so that we can share it with everyone, because I think you've covered a lot in terms of the questions that we get as an organization with Compassionate Hands and Hearts, and just me with talking with breast cancer patients. Some of those are questions that they always ask me. I was like, I don't know, but I'll ask the doctor. So thank you again for your time. We appreciate you and all that you do in the community.
Absolutely. Thank you, everyone. Have a
Thank you
wonderful
very
weekend.
much.
All right. Thank
Appreciate
everybody for joining us. And again, I think I went through all the questions. Feel free to email us if I forgot, and I'll get the answer for you. So everybody have a great Saturday, and thank you again for joining us for the first Saturday Conversations Talk with the Doc with Dr. Devina McCray.
Thank you.
Thanks, everybody.